Hello and welcome back to C3IFT. We're going to go ahead and start Module 2. Module 2 is going to be all about lines and devices. Sometimes when we take patients on transports, they have more than just a regular IV. Sometimes they have some very advanced lines that we're going to need to know how to deal with in the transport environment. We're going to start things off with central access lines. Central access lines are lines that are placed in the patient's central circulation. It can range from very simple PICC lines all the way up to arterial lines and Swan catheters. Some of these things we're going to be able to take in the C3 environment. Some of them are not. It's going to be important for you guys to know how to access them and what things you can mess with and what things you can't. PICC lines, or peripherally inserted central catheters, are lines that are placed through the patient's vein into their central circulation. If you have done the 2018 protocol update, you know that we can now access PICC lines in the field for emergent situations. Not really going to be any different in the C3 environment. It's going to be a place that we can access the patient, give medications through, give fluid boluses and that type of thing. A very common type of central line, very easily placed, and it's a line that can last for a very long time. Patients can have these in for up to 90 days. So very common with patients that are chronically ill and that have to have medications at home. So PICC lines are fairly easy to deal with. We're going to show you how to do that next. PICC lines are common for home infusions or patients that routinely require IV medications over a short period of time. Obviously, it's not something that's going to be left in over many years, but it can be left in for a couple months. They're easy to use and maintain. Oftentimes, they're maintained by family members. The big drawback is they can rupture under pressure. We have to use a 10 cc syringe or higher because of the PSI inside the smaller syringes. Using a 5 cc syringe or a 1 cc syringe, very high pressure inside of it, even when you're pushing it, and it could cause the catheter to rupture. So make sure you're using your 10 cc syringe or higher when you're messing with PICC lines. Steps for accessing the PICC line. We're going to scrub the hub every time we are inserting medicine into central circulation, so you want to make sure that hub is clean. If you end up inserting bacteria into the central circulation, that can be very bad for the patient. We always want to withdraw for blood. With PICC lines, sometimes they won't draw. Sometimes it takes a minute to get them cleared out if they haven't been used for a while. So withdraw for blood, but don't panic if you don't get any back. And then you want to flush with 10 cc's of normal saline. Assess for pain, swelling, or redness. Those are signs that the IV or the PICC line has infiltrated. Once this is complete and you have assessed that there's no pain, swelling, or redness and that it flushes easily, you can use the line.
So this is a PICC line. There we go. Okay. So here we have the clamp. Okay, and here we have a one-way valve. Okay. So we swab the one-way valve just to clean it effectively. Okay.
He is scrubbing the hub, just like we said.
Thing rather than the alcohol. The alcohol doesn't do a whole lot, if anything. So typically do this twice. And then again, like the port, essentially it's a 10 ml syringe, okay, filled with normal saline. Okay, so lure lock tip. So, and of course, opening the clamp. Okay, and first thing we do is advance it a little bit, and then we pull back, make sure we have blood draw back. Okay, you want to see the blood flow, and then we have to prime it a few times. So back and forth, just cleaning the whole port, or sort of PICC in this case. Back and forth. Back and forth. And the reason why we're using a 10 ml syringe is because the pounds per square inch is sufficient enough that it won't damage the internal structure of the PICC. If we go with a smaller 5 ml syringe, it can damage the actual internal workings.
Central venous lines are a lot like PICC lines. They go into central venous circulation. but they're a little more invasive and they're placed in the emergency setting. They're usually placed into the internal jugular, the subclavian, or a lot of times the femoral vein. They usually have 2 to 3 lumens or ports, and they're great for emergent access into very sick patients, infusing medications and fluids, and they're very easy to use, just like PICC lines. So here we have a picture of a central venous line going into the subclavian vein. Here, you know, then the external bit of that would be on the outside of the patient here. And in this picture, we have one into the IJ, or the internal jugular. 2 very common sites for placement of central venous lines. Here we have pictured a triple lumen central venous line. That really just means there's 3 of these little ends on the end of it. That makes it a triple lumen or a triple port. It really doesn't matter which one you use. They're all coming out at the same place. I was confused as to what they all meant. Really, it doesn't mean anything. You can use any one you want. It's really just to have a couple different points to plug in medicine. If you have a pressor running through one, you can use IV fluid on the other. Leave one open for medicine pushes. It really doesn't matter. You'll also notice that the catheter is shorter than the PICC line. It's because it's not going into the vena cava as the PICC line was. We just want to get into venous circulation. So steps for access: scrub the hub every time, just like everything else. Withdraw for blood, then flush gently. These are a little thicker, a little more robust. You can use the smaller syringes on these. It doesn't really matter. They're thicker and they're not going to rupture like the PICC line will. Arterial lines are going to be a no-go zone for the C3IFT paramedic. How you're going to know it's an arterial line and not a central venous line: you're going to have to look at the middle of it and see if there is this transducer, is what that's called. That's going to be located somewhere around the patient's fourth intercostal space, either taped to the patient's chest or the bed rail right beside them. You'll see this funny looking thing connected to a monitor, producing a waveform. That's going to tell you that it's an arterial line. Also, you'll see a pressure bag attached to arterial lines. There has to be some flow of normal saline. Even if they're not getting fluid at that time, there has to be a little flow through it. Otherwise, the blood inside the patient is just going to run back up into the bag because it's under pressure. So there'll be a pressure bag connected to the arterial line, and you'll see a transducer producing a monitor waveform. That's how you're going to know that this is an arterial line and not a central venous line, and you're going to know to stay away from it. Inform the doctor, inform the nurse, hey, I'm sorry, but I'm not going to be able to take this patient. Implanted ports, sometimes you hear them called sub-Q ports, vascular access ports, or power ports. These are ports that are implanted under the skin and are accessed with special equipment. These ports are really common in patients that are chronically ill over many years and become very hard peripheral IV sticks. Cancer patients, organ transplant patients, things like that, where they have to get IV access on a regular basis, they'll end up putting this port in because their peripheral veins just get burned out. It's implanted under the skin and it goes into central venous circulation, just like a PICC line, but it's more permanent. It's a access point that can stay there for many years. Accessing an implanted port or a power port can only be done with special equipment and training. It's actually a sterile procedure where they go and access this port, not something that we're going to be able to do. However, when that patient goes to the outlying hospital, they access their implanted port, then we can take that and use it as an IV while we're doing the transport. So if the port looks like this, like where they have it accessed here, there's a sterile dressing over it with that butterfly looking thing on there, and then a regular IV end down here at the end, that's been accessed and we can use that just like any other IV or central venous line. Give it a little flush, make sure it works, withdraw some blood, and you're in business. Again, we always scrub the hub. The Swan-Ganz Catheter is a really complicated device. It had fallen out of favor for a long time, and they're starting to make a comeback now. It's either inserted through the cephalic vein in the arm or the IJ in the neck, and it actually goes down into your heart. Not just into the vena cava like most central venous lines, it actually goes into the heart. The bottom line is this is a no-go zone. You cannot take this catheter without invasive monitoring capabilities. If the catheter shifts or it moves, you can occlude the pulmonary artery and thus kill your patient. if you're not paying attention. So you have to have invasive monitoring capabilities. There's advanced training that goes along with it. You have to know when to pull it back, when to leave it alone. So if you see some funny looking yellow thing with a bunch of lines and transducers coming out of it, just walk away. Tell the doctor, tell the nurse, hey, is that a Swan catheter? Because if it is, I can't take it. Very complicated device. Foley catheters, fairly simple. I'm sure all of us at one point or another have taken a patient somewhere with a Foley catheter. Essentially, the catheter goes through the urethra, advances into the bladder where you inflate the balloon, and then urine will drain and flow out to the collection bag. Very simple devices, very common. We see patients all the time with Foley catheters. Foley catheters rarely require any intervention. Most of the time, the Foley catheter is hooked to the bed and it's draining out of the patient. We don't even know it's there. Sometimes they may require irrigation. If the patient has pain, feels like they need to go but they can't, they have the urge to urinate, and that you've detected no urine output for a long period of time, the Foley catheter may need irrigated. This especially becomes important on long transports. Irrigating the Foley catheter is really simple. Basically, you take the cap off, you hook up a syringe of normal saline, flush it in, wait for it to come back out. You have successfully irrigated the catheter. It's really, really simple. We're going to show you how to do it when we bring you in for the hands-on stuff. Also worth noting, normal urine output. 1 to 2 cc's per kilo per hour is normal urine output. There's a couple different scenarios where urine output becomes really important. One of them is burns. Once you get past that initial Parkland formula, should you be taking a patient to the burn center where it's a really old burn and they've gotten past the initial bolus, fluid now is really titrated to urine output, so you're going to have to keep a really close eye on that urine output. Also, when patients are on a bunch of pressors, when the body goes into preservation mode and starts shunning blood away from vital organs, the kidneys oftentimes don't get perfused enough. So we want to make sure we're keeping enough fluid in the patient to where they're getting 1 to 2 cc's per kilo per hour of urine output. Suprapubic catheters work just like a Foley catheter, but it bypasses the urethra. These are usually inserted when there's some type of problem with the external genitalia or the prostate in males, usually prostate cancer. So it just goes through the stomach into the bladder and urine drains that way. The ends are just like the end of the Foley catheter. There's a collection bag and a place to flush. Chest tubes are something that we can take in the C3IFT transport environment. It's used for relief of a pneumo and a hemothorax. It's implanted into the chest cavity and hooked to a thoraceal. It's a liquid device that equalizes the pressure in the chest and allows blood and air to drain out. The big thing with C3, at least right now until the update comes out, is that chest tube must be clamped off. You can't have it hooked to anything during transport. Long story short, when it's hooked to something, it requires a little bit of suctioning to maintain that seal. So right now, they don't want you to mess with that. The chest tube can be in there and in place. It just has to be clamped off at the end. I spoke on the last slide about a thoraceal, and this is what this is here. It's essentially a hydraulic drain for the chest tube. The changes in pressure accompanied with a little bit of suction that you hook up to the thoraceal allows fluid and air to drain from the chest cavity. Here are some different types of thoraceals, but keep in mind the C3IFT medic can only take a chest tube that is clamped off and secured. It cannot be hooked up to a thoraceal for the duration of our transport. I'm sure everybody remembers med math from paramedic class. We took a drip set and our stopwatch and we timed out the drips. Most drips that were taken out of the hospital are going to have to be on a pump because we really need that high degree of accuracy. If you remember from paramedic class, when we were timing stuff with our watch, we could get pretty close, but the really high degree of accuracy just wasn't there. So that's where the IV pump comes in, and the IV pump will ensure that accuracy. A couple things with IV pumps. Most modern ones have every medicine known to man in there. You pick the medicine you want, you put in the patient's weight if you need to, and it will program the drip for you, so there's no math involved. Sometimes there is math involved, and it's always good to check the math to make sure that the math was done correctly. They come in all shapes and sizes. The best thing I can tell you, be familiar with the IV pump that your facility uses. So to review this section of C3IFT, A couple things: always check your lines for patency before you leave the facility. I can't tell you how many times I've got down the road, needed to give a medication, some Zofran, some pain medicine, whatever, and went to use the IV, and it doesn't work. It's either blown, infiltrated, whatever. So check them before you leave the facility. You didn't put it in, so make sure you check it before you leave. Always scrub the hub to reduce infection. We should be doing this on peripheral lines also. I know we don't always do it, but anytime you put something in an IV, you should be scrubbing the hub. If you're ever in doubt about a line or device, talk with the sending physician or consult medical command. If there's something crazy attached to that patient that you've never seen before, ask the doctor or the nurse, hey, what is that? I've never seen it before. There's no harm in that. We don't deal with that stuff all the time. They're not going to look down on you for it. Or call MedCom and say, hey, there's some crazy thing attached to this patient. I don't know what it is. Will you help me through it? So that concludes lines and devices. A lot of this stuff we're going to go over and let you put your hands on it once we get to the face-to-face portion of this class. So I hope this helps you and guides you in the direction of being comfortable with these lines and devices.